Intra-Op haptic kinking. Why did the haptic deform and what is the next step? While injecting the IOL inside the capsular bag, and this is type of 3 pieces Avanci from Kowa IOL, you can see the leading haptic, and I noticed that the trailing haptic is kinked. So now what should we do and what is the next step? Let's watch our case. Here is a case of phacoemulsification of 84-year-old male patient. I started with 2 paracentesis and 2.4 clear corneal incision, injecting intracameral migraine to dilate the pupil. Here's I'm using the capsule laser, so I apply HPMC over the cornea, then staining the anterior capsule under the air bubble using the capsule blue, followed with washout of the capsule blue and injecting dispersive OVD in back fill technique. And as we can see, our pupil dilatation is not that good. So I used the Malagin ring to dilate the pupil as usual. Here is I'm going to apply the capsule laser to create a well-centered, well-sized 5.3 millimeter diameter capsular rhexis as it's clear. We can see the type of the cataract. It is a dense nucleus. So in this case, I used the vertical chop technique after doing the hydrodissection and injecting also another dispersive OVD, and I use the vertical chop technique to emulsify this dense cataract. Let's back to the IOL. I don't have any financial interest, but there are a key difference between the Avanci 3 pieces and between the traditional 3 pieces regarding to the delivery system, which is fully preloaded in Kowa Avanci. However, we need manual loading of the IOL in the traditional pieces of the IOL. And also there is difference in the haptic material, which is made from the polyvinylidene fluoride PVDF for the Kowa Avanci, which is extremely flexible and resistant to breakage. However, in traditional 3 pieces IOL, the haptic material is made of polymethyl methacrylate PMMA, which is more rigid and prone to permanent kinking if mishandled. Also, we can see the optic edge, which is 360-degree square edge in Kowa Avanci, extends fully around the lens, including the optic haptic junction. However, this continuous square edge in the traditional 3 pieces at the haptic junction where cell can migrate. So let's back to our case. Here's the time of injecting. Our enlargement of the main phaco incision was not enough. That's why the tip of the injector cannot enter into the anterior chamber. Here is I remove the IOL from the cartridge and manual loading. This is IOL in the cartridge of single piece IOL. As we can see, while injecting the IOL, the haptic is kinked by the plunger of the injector. But as the IOL is from Kowa, which is from PVDF material, so it was easy to readjust and back it to its normal memory, as we can see. Actually, in this type of the IOL, the kinking is not permanent like the traditional IOLs. Then injecting and implanting the IOL properly inside the capsular bag, as we can see. Also, trying to test the haptic inside the capsular bag. As we can see, I push the IOL slightly, then removing the Malagin ring, and here is the end of the surgery. Wash out the viscoelastic. So the main causes for our problem here is the enlargement of the main phaco incision was not enough to introduce the tip of the cartridge of the preloaded Avanci 3 pieces IOL, and also using the cartridge of single piece IOL, we should use a cartridge of 3 pieces IOL. Here is the end of the surgery. Thank you for watching.